The today's session is Spirochetes. So spirochetes are thin, flexible, elongated, spirally coiled helical bacilli. The word spira means coil and chete means hair. Most of the spirochetes are saprophytes. Only three are human pathogens: Trypnoma, Borrelia, and Leptospira. These three are the human pathogens. First one is the syphilis. It is one of the ancient sexually transmitted disease. The name was derived from a famous poem in the year 1530, which described a legend of shepherd boy named Syphilis who had suffered from the disease. From this poem, the word name syphilis was derived. Next one is the transmission of syphilis. Mainly, that syphilis is transmitted mainly by sexual contact. In some cases, it will be transmitted by non-venereal modes such as direct contact, blood transfusion, or transplacental transmission. Incubation of syphilis is variable. It will last for 9 to 90 days and it is inversely proportional to number of organisms inoculated. Next one is a clinical manifestation of syphilis. Approximately 30% of persons who have sexual exposure with an infected partner will develop syphilis. It will pass through various stages: primary, secondary, latent, or tertiary, which is otherwise known as late stages. First one is a primary syphilis. In primary syphilis, chancre formation will be there. Single and in painless indurator ulcer is seen. The most common site for primary syphilis is penis in males, cervix or labia in females. Usually, regional lymph node involvement will be there, which is painless, firm, non-suppurative. Often in primary syphilis, it is often bilateral. If syphilis is acquired by non-venereal mode, it is transmitted by direct contact. Mainly, the primary chancre is mainly extragenital. Usually, it is seen in the fingers. It is transmitted by blood transfusion. The primary chancre does not occur. Next one is a secondary syphilis. It will develop 4 to 8 weeks after healing of primary lesion, in which skin rashes will be there. The skin rashes is mainly it is seen in the palms and sole. Condylomata acuminata, mucocutaneous lesion, and mucus patches will be seen, which is otherwise known as superficial mucosal erosions, and generalized lymphadenopathy will be there in secondary syphilis. Next one is a latent syphilis. In latent syphilis, absence of clinical manifestation of syphilis, but the positive serological tests will be there. Normal cerebrospinal fluid findings in patients with history of primary and secondary syphilis in the past will have latent syphilis. Early latent syphilis, it will occur within first year after infection. Late latent syphilis, it will occur first year after 1 year. The patients are still infectious and transmitting the infection either by bloodstream or in utero. And in latent syphilis, it will may have the following fates. One is the persistent lifelong infection is more common in latent syphilis. Developmental late syphilis, it is very rare. And spontaneous cure with serological tests becoming positive, it is also very rare. Next one is a late or tertiary syphilis. 1/3 of untreated patients will develop this late or tertiary syphilis. Gamma, it is a late benign syphilis. It will occur in 50% of people. Next one is a cardiovascular syphilis. It will occur in 10% of people. In cardiovascular syphilis, mainly aneurysm of ascending aorta and aortic regurgitation will occur. Next one is the neurosyphilis. It will occur in 10% of people. Invasion of central nervous system. It occurs in first few weeks of infection, but manifestation will develop only in the late stage. Central nervous system and cardiovascular lesions. It is also called as quaternary syphilis. General paralysis of insane. Tapes dorsalis, which means demyelination of posterior columns. Meningeal syphilis, in which meningitis is seen. Meningovascular syphilis, in which vasculitis of arteries that will lead to embolic stroke. Next one is the congenital syphilis. Congenital syphilis is mainly transmitted by during the pregnancy, but the fetal damage will occur only after the fourth month of gestation. Some common manifestation of congenital syphilis are it will occur within 2 years of age. The affected children will are very infectious and they will suffer from rhinitis, which is otherwise known as snuffles. Mucocutaneous lesions will be seen in bone changes will be there in congenital syphilis, and hepatosplenomegaly and limb adenopathy is seen. In late congenital syphilis, it will occur after 2 years and it is not infectious. In late congenital syphilis, it is mainly characterized by interstitial keratitis, eighth nerve deafness is seen, and bilateral knee effusion is seen, which is otherwise known as Clayton's joints. Residual stigmata may remain for a long time, such as in congenital syphilis, Hutchinson's teeth nose central incisor is seen, and the molar teeth will look like mulberry molar, saddle nose, and saber shins is seen. Next one is a laboratory diagnosis of syphilis. First one is the microscopy. Under dark ground microscopy, Trypnoma pallidum, it will appear as a slender, flexible, spirally coiled bacilli with tapering ends, and three types of motility is seen. One is flexion extension type, and the other one is the corkscrew motility, and the third one is the rational with soft bending at midpoint. The sensitivity is 80% with a detection limiter 10 power 4 bacilli per ml. Next one is a direct fluorescent antibody staining for Trypnoma pallidum, which is 100%. Next one is the silver impregnation method. First one is the Lividitini stain, which is used for tissue section, and Fontana stain, which is used for smear. Next one is the culture. Pathogenic trypnomas, it will not be grown in artificial culture media, but it is maintained only in the rabbit testis. It is non-pathogenic trypnomas, example writer trypnomas. It can be cultured only in Smith Nagachi media. Next, through serology, antibody detection, and PCR, it is diagnosed. Next one is a venereal disease research laboratory. It is a slight flocculation test. It is a type of precipitation reaction. In venereal disease research laboratory, the antigen preparation is done by mainly the cardiolipin antigen, which is derived from bovine heart, to which cholesterol and lecithin are added. Antigen has to be reconstituted with buffer and it should be used within 24 hours. Patient serum preparation. Inactivating serum by heating at 56 degrees Celsius only for about 30 minutes, which will remove the non-specific inhibitors. Venereal disease research laboratory slide containing totally 12 concave rings are used. Next one is the qualitative test. Drop of inactivated serum is mixed with a drop of venereal disease research laboratory antigen, and the slide is rotated for only for about 4 minutes. Next one is a non-reactive. It is uniformly distributed fusiform crystals which represent the presence of venereal disease research laboratory antigen only. Next one is the reactive. Medium to large plum, it will signify antigen antibody complexes. Next one is the Venereal Disease Research Laboratory cerebrospinal fluid. It can be performed to detect only the cerebrospinal fluid antibodies. However, no preheating of cerebrospinal fluid is needed. Next one is the advantages of non-treponemal tests. The monitoring the response of treatment. Reagin test is usually become negative 6 to 8 months in congenital syphilis, depending on the stage at which treatment is given. In neural syphilis, venereal disease research laboratory can be used to detect CSF antibodies. Reagin antibodies will be detectable only after 7 to 10 days. in which the appearance of primary chancre is seen, or it will use for 3 to 5 weeks after infection. Next one is the sensitivity of non-treponemal test. It will varies from 78 to 85% in primary, 10% in secondary, 95 to 98% in latent stage. Next one is the disadvantages of non-treponemal test. Biological false positive reaction. It is defined as positive non-treponemal test with negative treponemal test. It is not caused by technical fault and in which no clinical feature is seen. This non-treponemal test it occur only in 1% of cases. BF antibody is usually of immunoglobulin mediate M type, while reagin antibodies in syphilis is mainly immunoglobulin G type. Next one is the types of biological false positive. The conditions in which biological false positive reaction occur, it can be classified into acute biological false positive. It will persist less than 6 months. Example in acute infection, injuries or in inflammatory condition. In chronic biological false positive reaction, it will last for more than 6 months. Example, it is seen in systemic lupus erythematosus and other collagen disease such as rheumatoid arthritis. And other conditions include lepromatous leprosy, relapsing fever, malaria, tropical pulmonary eosinophilia, viral hepatitis, infectious mononucleosis, HIV, pregnancy, and intravenous drug abuses. It is seen. Next one is a proson phenomena. It is false positive antibody titer in patients sera is very high. Next one is the sensitivity of non-treponemal test is very low in the late stage of syphilis. Next one is a screening test. Test should be used to confirm the treponemal test. If treponemal tests are found positive, it will confirm the syphilis. If the treponemal test is negative, it indicates false positive non-treponemal test. Next one is the diagnosis of congenital syphilis. Mainly, it is diagnosed by demonstration of Treponema pallidum by dark ground microscopy of umbilical cord, placenta, nasal discharge, skin lesion. Presumptive diagnosis: infant born to a mother who had syphilis at the time of delivery. Regardless of findings in the infant, reactive treponemal test in infant is done in congenital syphilis, and one of the following additional criteria is used. Clinical signs or symptoms of congenital syphilis, abnormal cerebrospinal fluid findings without other causes, and reactive venereal disease research laboratory CSF test, reactive immunoglobulin M antibody specific, it is for syphilis. As immunoglobulin M, it will not cross the placenta. Its presence is neonatal serum. It will confirm the diagnosis of congenital syphilis. Next one is a screening of congenital syphilis based on venereal disease research laboratory test. Serial immunoglobulin G in baby it is used. If maternal transfer titer falls in 3 months, the screening test is done. If congenital infection titer rises in 3 months, screening test is done. Simultaneous VDRL test of mother and baby is done if the mother's titer and baby's titer indicates the maternal transfer. If the baby's titer is greater than the mother's titer, it will indicate congenital infection. If mother's titer is greater than baby's titer, it will indicate maternal transfer. Sample baby serum is the most appropriate. Cord blood and maternal serum. Mode of transmission by direct contact, not sexual contact. Age of acquisition, mainly in the childhood. Geographical distribution, mainly it is seen in rural areas of developing nations. Travelers in developed nations. It is associated with pure hygiene. Next one is the features of venereal syphilis. Yes, endemic syphilis and Pinta. The venereal syphilis, the main agent is Treponema pallidum. It is mainly transmitted by sexual and transplacental blood. Age most commonly it is seen in adulthood. Primary lesion, chancre, which is painless, non-indurated and lymph adenopathy is seen. Site of lesion is genital, oral, and anal. In secondary lesions, skin rashes, mucosal patches, condyloma lata is seen. Relapses is only 25%. In late complication of venereal syphilis, gummas, CVS, and CNS lesion will occur. Next one is the YAS. The agent of YAS is Trypnoma pretinae. Mode of transmission is due to skin contact. Age is early childhood. Primary lesion papilloma is seen, which is often ulcerative and lymphadenopathy. Site of lesion most commonly as is seen in the extremities. Secondary lesions, skin lesions, macular or papilla, periostitis is seen. Relapses is more common. In late complications of YAS, destructive gummas of skin, bone, and cartilage is seen. Destruction of nose, maxilla, palate, and pharynx, which is termed as gangosa. In YAS, no CNS or serious lesion will occur as late complication. In endemic syphilis, the agent is Trypnoma endemicum. Mainly, it is transmitted through household contacts by kissing, sharing utensils or insect. The age is early childhood. Primary lesion, it will occur very rarely. The site of lesion of endemic syphilis is mostly it is seen in the oral. Secondary lesions, oral mucus patches, periostitis, lymphadenopathy, and the relapses is unknown. Pinta, the agent is Trypnoma cariatum. Mode of transmission is through skin to skin contact. Age is mainly affected late childhood. Primary lesion is non-ulcerating and pruritic papule is skin. Site of lesion, extremities and face. Secondary lesion, pinnitis, pigment and pruritic lesions is seen. Relapses will not occur in Pinta and late complication. It is non-destructive, dyschromic macule. No CNS or serious lesion will seen in Pinta. Next one is the Borrelia. Relapsing fever is so named because alternate period of febrile and afebrile episodes will occur in Borrelia. So it is otherwise known as relapsing fever. Reason for relapse is antigenic due to antigenic variation. Mainly it is shown by the causative agent Borrelia recurrentis. Lab diagnosis, microscopic examination of blood, wet limb under dark ground of phase contrast microscope, GEMSA and Leishman staining or quantitative Buffy code staining is used. PCR is more sensitive for Borrelia and speciation is possible for the diagnosis. Serology mainly by the antibody detection. ELISA, indirect immunofluorescence assay. It is not reliable. It will give false positive in Borrelia. And GIPQ assay, it is the most reliable serological method for diagnosis in Borrelia. It is an immunoblot assay detecting antibody against the glycerophosphodiesterase antigen. Animal inoculation into intraperitoneal infection. Some molecular methods are used to diagnose Borrelia, such as multiplex real-time PCR. It has been developed targeting cysteine SR, RNA, and GIPQ genes. Next one is the Lyme disease. The agent for Lyme disease is Borrelia burgdorferi. The transmission of Lyme disease is mainly seen through tick-borne, which is otherwise known as Ixodes ricinus. The clinical manifestation, it consists of triad of first one is the in stage 1 erythema migrans is seen, which is an annual lesions. Next, in stage 2, disseminated infection will occur, such as skin lesion, meningitis, neuritis, nodal block, or joint pain will be there. In neurological abnormalities, it will occur in 50% of cases. It will include meningitis, encephalitis, and a typical lymphocytic meningoardiculitis. It is seen in cases from Europe and Asia. It is also called as Banvard syndrome. In stage 3, persistent infection in which arthritis, encephalopathy, or acrodermatitis is seen. Next one is a lab diagnosis. The diagnosis of Lyme disease is mainly on clinical ground. Isolation from skin lesion or blood, modified Kelly's medium. In microscopic detection, dark ground phase contrast immunofluorescence silver staining is used. Antigen in urine is used for lab diagnosis. Next one is the antibody detection. ELISA and Western blot. First month, both immunoglobulin M and immunoglobulin G. Later, immunoglobulin M will disappear. Limitations for antibody detection is it will persist for long time. False positive is unrelated infection. Fourfold rise of antibodies more significant. Next one is a two-step test approach. CDC recommends to perform ELISA first. It is confirmed by Western blot. C6 peptide, immunoglobulin G ELISA, PMNS in joint fluid by limbocystosis in CSF. Next one is the Borrelia vincentini. It is the common cell of mouth. The main important disease is Vincent's angina. Ulcerative gingivostomatitis is seen. It is a predisposing condition that such as malnutrition and viral infection. It will occur. Often it is associated with fusiform bacillus leptotrichia, which is otherwise called as Fusobacterium fusiformis. Next one is the Leptospira. Classification species of Leptospira. It has two species. One is Leptospira indrogens and Leptospira biflexa. Leptospira biflexa is a saprophyte. Leptospira indrogens, it is a pathogenic for humans and it will causes leptospirosis or Wales disease. It involve liver and kidney. Serovas and serogroups. Leptospira indrogens, it totally comprises of 25 serogroups. It further consists of 250 serovas. All serogroups and serovas are morphological identical and it will produce the same clinical picture, but it will differ in geographical distribution and severity of infection. Next one is the epidemiology. Mode of transmission, mainly it is through zoonotic. Direct human to human transmission will not occur. It is mainly transmitted by indirect contact with water, moist soil, wet surface contaminated with animal urine, or dark contact with urine and products of parturition, placenta of infected animals, through which this way it is transmitted. Next one is a source. Although more than 100 animals can be infected, but important source of infection are mainly seen in rats, dogs, cattle, and pigs. Three R's are important in Leptospira. Important epidemiological determinant for Leptospira include mainly rodent spread is the one of the most important during rainfall and rice field. Global distribution, Leptospira is worldwide in distribution. The highest burden is mainly seen in Brazil, India, and Thailand. In India, the leptospirosis is mainly endemic. It is seen in Tamilnadu, Kerala, and Andaman. So it is called as Andaman hemorrhagic fever. Regional Medical Research Center is the National Leptospirosis Reference Center of India, which is located in Port Blair. Next one is a clinical manifestation of leptospira. The incubation period of leptospira is only about 5 to 14 days. The manifestation can be divided into two distinct clinical syndrome. One is mild and febrile illness. It will occur in 90% of patients. It is biphasic, septicemic phase followed by immune phase. Other one is the Wales disease, hepatorenal hemorrhagic syndrome. It is a severe form of icteric illness. It will occur only in about 10% of patients. Typical biphasic course may not be present. It is more severe and fulminant. Next one is a laboratory diagnosis of leptospira. CSF and blood in first 10 days of infection and urine between 10 to 13 days of infection. Under microscopic appearance, the leptospira will appear as thin and under a dark green microscope, they are tightly and regularly coiled with characteristic hook ends like umbrella handle appearance. It will be seen under microscopy. They are highly motile and exhibit spinning and translational movements. Next one is the isolation. First one is the culture condition. Leptospira is an obligate aerobe and it is a very slow growing organism. It will be incubated at 30 degrees Celsius for 4 to 6 weeks. The culture media, it is a very highly fastidious, so it requires enriched media such as Ellinghausen, MC Kullard, Johnson Harris, most commonly used media, Courthouse media with rabbit blood, and Fletcher semi-solid media is used for culture media. Next one is the disadvantages. Culture technique is laborious, technically demanding, and it is time consuming. False positive results, it will occur due to contamination of culture media. False negative results, it will occur due to antibodies or incubating in improper temperature and pH. Next one is animal inoculation. Mostly it is inoculated into hamsters 4 to 6 weeks old and young guinea pigs. Serology for antibody detection. Antibody detection tests can be broadly classified into genus specific tests. It is uses broadly reactive genus specific antigen, which is prepared from non pathogenic Leptospira bifluxa patac 1 strain. It cannot detect infecting serovar. Various testers are available nowadays. Macroscopic slide agglutination test, microscopal capsule agglutination test, latex agglutination test, ELISA, ICT Sarova specific test, microscopic agglutination test. It will detect only antibodies against specific Sarovas of Leptospira intragans. It is one of the olden gold standard method reference test for diagnosis of leptospirosis. Next one is the molecular method. Various genes such as 16XS or 23S or RNA or IS 1533 insertion the sequence are targeted. PCR will detect early before seroconversion occurs. However, PCR is not serova specific. PCR, RFLP, or pulse field gel electrophoresis are the methods to determine the genospecies of Leptospira. Next one is the FAINS criteria. It is approved by WHO. It is useful for the guidelines for the diagnosis of leptospirosis. It is mainly based on clinical and epidemiological and laboratory findings. Some non-specific findings such as altered renal function and liver function tests is seen in leptospirosis. Thank you.